So, I mean, this man needs no introduction whatsoever. Talk about mentor. He's a mentor to probably, 3/4 of people in this room. So Dr. Miller is my mentor. The reason why I got into sports medicine in the first place, probably the reason why I got into UVA in the first place. So without further ado, again, needs no introduction. Dr. Mark Miller is going to talk about the history of knee surgery.
Thanks.
Yeah,
So I was asked to give this talk, and I'm happy to do that. And I very much welcome everybody coming back for this, and I'm honored and humbled to do this. I was asked to become a career advice lecture, and I said, well, I kind of been working on this history of sports knee surgery. How about if I do both? And so therefore, I'm going to give you 2 lectures. This is a little bit longer, the other is shorter, but still within the time frame that I was requested. All right, so we'll start with the history of sports knee surgery.
Seems like the hardest thing.
These are my disclosures. So why should you study history? Well, those who do not learn history are doomed to repeat it. And there's nothing new in the world except the history you do not know. So let's see if we can learn a little bit of history to keep and avoid those mistakes the next time. So this is the way we're going to approach it. We're going to use the method. We're going to tell you what we're going to tell you. We're going to tell you, and then we tell you what we told you. Okay, we'll do that for both lectures. So we'll start with the cruciate ligaments, go to the multiple ligament, which also includes the collateral ligaments and the corners. Talk about the meniscus, articular cartilage, Dr. Didek's favorite patellofemoral joint, just briefly, because I don't want to, obviously not an expert like he is. And the knee arthroscopy, which I credit Dr. Guadmi for borrowing a few of his slides on this. He has a whole lecture on knee arthroscopy. So you can see we've got to go through a lot of material very quickly. So let's start with ACL. Here's some sources for the ACL history. So let's start with a quote. Stitching the ligament is absolutely futile. Natural statistical tissue is the only reliable means of repair. Sir Robert Jones, 1916. We'll talk about the early years. We'll talk about ACL repair, extra-articular procedures, which started with the medial side and then went to the lateral side. This is a very interesting discussion. Intra-articular procedures, talk about the exam, fixation, arthroscopic ACL reconstruction. The advent of arthroscopy permeates throughout this whole talk, and then briefly on double bundle ACL reconstruction. So that's the way we will proceed. So early years. Believe it or not, the ACL has its origins in the Edmund Smith papyrus back in 3000 BC. Hippocrates picked it up in 400 BC and Galen in 200 AD. Then we jump forward to the 19th century. The Weber brothers in Germany described the bundles, Bonnet in France, cadaveric studies, other studies from ancient Greece, not ancient Greece, but Greece. And the Sagone, we all heard the eponym Sagone. He described his fracture in 1879. And then Godis in Germany had detailed studies of ACL rupture in 1913. How about ACL repair? Well, this was first described at the beginning of the 18th century. Battle, Mayo Robinson, and then Jones in England. And then the famous ones in our lifetime is Fagan and Curl. They did studies of West Point, and after initial success, after 1 year, their 5-year studies showed that they failed. A high failure rate. And yet, here we are returning to this ACL repair with newer devices. And the question is, be skeptical about the results of this. How about extra-articular procedures? Well, this is very interesting because our forefathers thought that the pivot shift phenomenon was based upon medial laxity. And we now know that after initial failures with that it's really based upon lateral laxity. And so that's why extra-articular procedures are now, even to this day, done laterally rather than medially. And then there were combined procedures, and then we lost popularity of that and started to do just intra-articular procedures. And now we've cycled back to the resurgence of popularity in certain patients, particularly those with laxity and competitive sports, to doing intra and extra-articular combined procedures. So let's talk about this era of the medial based procedures, which didn't last very long in the early 70s. This whole concept of a pes transfer or transplantation simply involved flipping the pes insertion and tightening up the medial side in that fashion. And so this was Slocum's pes transplant. And then Nicholas took it one step further. And not only did the pes transplant, but also in all cases, even with normal meniscus, did a total medial meniscectomy, and then several other procedures to tighten up the medial side. You can imagine this resulted in some medial arthritis. Then all of a sudden, people changed their focus, and it's not a medial problem, it's a lateral problem. And perhaps one of the most colorful descriptions of this is Ron Lose. He has this book entitled Doc, and he was the first US surgeon to discover that the pivot shift phenomenon was based upon a lateral problem and not a medial problem. In his book, he notes, I elevated his partially flexed knee. I took his left foot in my hand. I further flexed his knee. I must have been squeezing the lateral compartment of the joint while bending in this way, and nothing happened. But when I extended the knee in the same manner, the knee gave way. At this stage, I had no idea what was happening. I had to figure this out because I convinced that I'd made a discovery. Because of the strong evidence of the time, those who thought that the instability was based on medial instability, I did not see that every time I tested it, an impressive, unusual shift occurred at the lateral side of the knee. So Doc Lose described this in 1969. And after he did this further, he contacted the surgeons in Canada, and especially he was introduced to McIntosh, and McIntosh had already developed a lateral-based procedure for extra-articular reconstruction. And then, of course, Lose modified that. And so here we have these various lateral-based procedures, some which we do modified cases of even to this day, of lateral extra-articular tenodesis. McIntosh, and then the Lose modification of the McIntosh, Ellison, and Lemaire, all famous surgeons who recognize the importance of lateral-based procedures. And then augmentation was popular to do an intra and extra-articular augmentation. And then this landmark study in the 1991 said that you do not need to do a lateral extra-articular tenodesis, just an intra-articular tenodesis, just an intra-articular procedure. And so this retrospective study of only 67 patients with no subgroup analysis changed the thought process for 20 years in ACL surgery. And so we no longer did extra-articular augmentation and probably had a lot of failures in certain patients because we abandoned this. And then recently, there's been a resurgence of interest, especially with people with have high laxity and people involved in competitive sports. And Al Gitgood gets credit for a lot of this with the Stability 1 trial that he did hamstrings and then supplemented with extra-articular procedures with good results in those patients. The Stability 2 project will be published very soon. They just concluded their last enrollment, and so we expect results of patella tendon and quadriceps graft with extra-articular augmentation as well. And so this is important then to recognize we do intra and combined extra-articular procedures in certain high-risk patients. And then this LET, or modified Lemaire procedure, we do for that, but there's also popularization of the ALL, which is one of these rediscovered ligaments that have been discovered all along. And various people had various complex and various surgeries to do the ALL rather than the LET. Here at UVA, we've been doing the LET. And so as we go through this then, the intra-articular needs to get some emphasis as well. So intra-articular ACL reconstruction had its origin in the early 20th century. Fascial grafts, then semi-T grafts, then bone patella tendon grafts. The medial third was used first, and then the central 1/3 was popularized by Jones in 1963. And he had the right idea, but look where he put his graft. It was so non-anatomic that it resulted in failure. And it's a shame because this didn't catch on until much later because the graft was not anatomic. And so it did become more popular as we discovered the anatomy and reproduced the anatomy. Buckner in Germany, Erickson and Franke in the same issue of OCNA in 1976 popularized the central 1/3 patella tendon graft. Quadriceps tendon graft, Marshall, Blouth, and recently Fulkerson and others described this, some with augmentation, some without. And then allograft had a short history as well, because although these were popular, especially even during my residency, Jackson in '96 demonstrated in animals they had delayed incorporation. And then West Point studies and other studies demonstrated a crazy high failure rate with allografts in young people. So nobody does allografts in young people anymore because of this high failure rate. Other contributors, a whole host of big names: Clancy, Warren, Rosenberg, Sorogens, and various Indelicato and others. Well, how about the history of the physical examination? Well, the anterior drawer test was described in 1875, and not till a century later was it popularized. The Lockman test, which is done in less flexion, was described by Torg and named after his mentor Lockman. The pivot shift test, again, Losey, actually described it in 69 with that description we share with you, but it wasn't published until 1978. McIntosh, 72, Houston's jerk test, not necessarily named by the examiner, in 1976. How about fixation? Well, we started with bone wedges, went to wire, sutures, and posts, used a regular AO screw for an interference screw, and then Kurosaka came along and developed what we now know as the interference screw, which has been popularized. Suture button device, absorbable devices or plastic devices, and now more recently, tensionable constructs. And how about arthroscopy? The advent of arthroscopy in the early 80s started with outside-in ACL reconstruction, transtibial, which was, I would submit to you, as a step backwards, and now independent femoral tunnel drilling, either outside-in, accessory media portal, or flexible reamers. It's like real estate. It doesn't matter how you get there. It's just how you get there. How about synthetics grafts? These had a very short success time trial based, and I would submit to you that we had a lot of setbacks here. Carbon implants that had debris scattered throughout the joint. Gore-Tex graft, if you ever had an opportunity to revise one of these, you realize what a disaster that was. And I submit to you maybe now, internal brace, also a synthetic graft, if you think about it. So Inyar Erickson says that artificial ACL substitutes are like shoestrings. Eventually they'll all break. And so here we had the LAD augmentation by Marshall McIntosh, and then on into the double bundle era. Freddie Fu, of course, gets credit for trying this. It wasn't as successful as he hoped clinically, but if nothing else, Freddie taught us the anatomy, and it helps us with even our single bundles to appreciate the anatomy of the two bundles of the ACL. So we talked about ACL, early years, repair, extra-articular starting medial, and then going lateral, intra-articular, exam, fixation, grafts, and then double bundle. Here's the timeline, and you look at most of this happened towards the second half of the 20th century into today. Let's move on to PCL. So here we have the PCL. Here's the sources, the quote: PCL is a central pivot point of the knee. So I was asked to give the lecture on history of the central pivot of the knee. It started my whole interest in this area. And I said, well, are you talking about the ACL or the PCL? And so they were talking about the ACL, but many people consider the PCL to be the central pivot of the knee. So we'll talk again, early years, repair, transpositions, different grafts, and the importance of what we call the killer turn, single versus double, just like in the ACL, and exam history. So early years. In 1903, Mayo Robinson described PCL repair. Haygrove's PCL reconstruction, the semi-T graft, others with different grafts and different tunnels. In the late 30s, Bosworth did a fascia lata graft. Others did different other grafts. Semi-T became popular. And then also PCL was repaired, was popularized. This is still important for avulsions, but early on they had reasonable results, but they had failures related to technical problems, because it's technically difficult to do repairs, as we know. And so this led to an era then of transpositions. So they take a different tendon and try to make it into the PCL. For example, the popliteus, the median of the gastroc, and this is crazy. They actually used the meniscus. They left the medial meniscus posterior horn intact, did a complete meniscectomy, and used the meniscus itself for a PCL graft. Talk about destroying the medial side of the knee. This was popular for only a few years, fortunately. Various other grafts: Clancy, patella tendons, Harner, allografts, quadriceps tendon, hamstrings. Various grafts have been used for PCL reconstruction. But the problem with all these grafts and reconstructions has been the transtibial technique and the so-called killer turn in the back of the knee. So Bergfeld and McAllister and others showed that there's a susceptible point for graft attrition when it goes around the back of the knee of that killer turn. And so there's been various strategies to try to obviate the killer turn, including in the mid-90s, Spinelli talked about taking several small turns. Berg did an open tibial inlay. And when I came here many years ago, I actually did the inlay open. Campbell, primarily at Virginia Beach, we studied this in the lab, did an arthroscopic inlay that's still popular. On did the posterior transeptal portal, which we introduced here as well. And then we've discovered that if you put the fixation way up proximally, you can also lessen the effect of the killer turn. And that's what we were doing towards the end of my time here. Single versus double bundle, just like in the ACL, it may have some advantages primarily in the lab, but it clinically really doesn't matter, and current evidence doesn't support the use of it. How about examination history? Well, we had the posterior sag sign described in 1903, posterior drawer test, most recently Houston in 76, reverse pivot, and quadricep active test by the late Dale Daniels in 1988. And then, so therefore, we talked about all these things in the history of PCL surgery. So we walked through the ACL, the PCL, and now we're going to walk on to the multiple ligament reconstruction. And so multiple ligaments, this is the PCL timeline. The sources for multiple ligaments shown here. The quote on multiple ligaments: there are scarcely any accidents to which the body is liable, which is more imperiously demand immediate amputation as these. And unfortunately, we've made some progress in that area. Again, early recognition and treatment, non-operative management, operative management, classification. And because multiple ligaments are involved with vascular injuries, we'll talk briefly on that as well. So the first recognitions, the fatalistic descriptions in the 1800s, and then finally some success with closed reductions. And Cooper in 1851 has an interesting quote: concealed within the joint are two strong ligaments, that's the cruciates, which pass crossways from the notch and are therefore called crucial. Although great strength is evident in the construction of this joint, still excessive violence and extreme relaxation will occasionally produce its dislocation. So that plus excessive BMI we've discovered in our own era. And so Hamilton said that these joint dislocations are rare, they do take place, and they describe the four different directions: anterior, posterior, medial, and lateral. And he provided several examples of each. In Fowler, 1911, described these external knee dislocation, and then some of the cross pinning and electronization done for temporary fixation of these dislocations. And then, of course, casting was very popular, closed reduction. And the problem there is that we didn't understand how to fix these, and therefore we simply casted them. That resulted either stiff knees or loose knees, and no in-betweens. And then there became popularized trying to do early management, either repair or different grafts for reconstructions. And then also a lot of early management of different collateral ligament reconstructions. And over the years, advancements were very popular. That is to try to take the existing structures and simply tighten them up by advancing them. As we went from advancements in, improved results then when we started using grafts, free grafts to supplement this. And then the debate, because, well, should we do it early? Should we do it late? The debate continues. And there are some studies underway that may answer that question for us ultimately. Again, the advancements, these were described throughout the 20th century. Basically, you take a bone block of the insertions and advance them to tighten them up with variable results. Perhaps the best results, though, were with free grafts. So the current mantra is to repair when you can, and then add a free graft to reconstruct it. This started with Clancy, the biceps tenodesis, and then Mueller, Larson, Noyes, and many others. And then we advanced it on to more anatomic reconstructions. Laprade, of course, is the father of anatomic reconstructions, both laterally and medially. Posterior medial corner, Bosworth, various free grafts, and again, Laprade has his anatomic reconstructions. Bosworth in 1952 actually took the semitendinosus and used it to tighten up the medial side. The modified Bosworth basically does the same thing, except that it puts it over a post, and this way you can check isometricity before you secure it distally. Classification, initially based upon the direction, and then Schenck based his classification based upon the number of ligaments involved, ACL, PCL, MCL, LCL. How about vascular injuries? Well, in World War II, there was a very high amputation rate. This got corrected with vascular repairs during the Korean and Vietnam Wars, and they markedly reduced the amputation rate if they could get to it especially early with vascular repairs or reconstructions. And we now know today that ankle brachial index, comparing the blood pressure in the arm versus the ankle, is very helpful to monitor these patients overnight. And we still admit people for ABIs, serial ABIs throughout the night. So this is what we talked about: multiple ligament, recognition, non-operative management, operative management, classification, and vascular injuries. Let's move on to meniscus. Menisci are the functionless remnants of interarticular leg muscles. Sir John Bland Sutton in 1900, and some people apparently thought that was still the case when they're describing some of these other procedures. So again, we'll talk about early and move on to different newer techniques. Sappho in 600 BC first coined the term meniscus. Hippocrates mentioned meniscus, as did Vesalius, and Morgani in 1709 demonstrated more in-depth studies. The first reduction of a meniscus tear was Bass. Broomfield described the meniscus flapping out of place. Others, Hay and Cooper, meniscectomy versus repair. Actually, the repair description preceded the meniscectomy description, which is kind of interesting. And then various other studies. King did dog meniscus repair. Fairbank described squaring, ridging, and narrowing, which we now recognize as arthritis, early arthritis from post-meniscectomy. Smiley, of course, the inventor of the Smiley knives. Even when we already had the descriptions of arthritis from medial side, many people still advocated for meniscectomy. And so gradually people recognized this was more and more a problem, and we tried to do repair whenever possible. So arthroscopy came along, and interestingly, meniscus repair was described as early as 1969. All of these surgeons from North America went to Japan to discover how to do arthroscopy, came back and developed increasingly better techniques for meniscus repair. Meniscus replacement, initially other grafts and ultimately allografts with meniscus transplantation, and there's still work being done on implants. How about examination? Well, I don't know when joint line tenderness was come along, but that was obviously one of the most important ones. But other provocative tests, such as McMurray, Apley, Childress, and Thessaly, have been described. So this is what we went through with the history of meniscus surgery. Let's move on to knee articular cartilage surgery. And so Hunter described in 1743 that an ulcerated cartilage is universally allowed to be a very troublesome disease. When destroyed, it is never recovered. That's still true to the day. So let's talk about debridement, microfracture, periosteal, perichondral grafts, allografts, autografts, and then transplantation. Well, first of all, debridement was popular early on, initially just a lavage, and then gradually drilling, spongilization, abrasion arthroplasty, and Stedman, of course, from Vail, described microfracture. Periosteum was introduced to the Mayo Clinic with a rabbit study. Other studies showed pretty good results and some just okay results. Just periosteum, nothing under the periosteum. And then perichondrium, usually from the rib, good results, but the problem is it was difficult to secure it. And then on to allografts. The first allografts were done in Canada where they had bulk allografts. They actually had people on beepers, and patients would be on a beeper standing by for someone to die and then jump in and have their allograft reconstruction in Canada. Bugby in San Diego did shell allografts, and then gradually oats and mega oats and bio-unis became more popular, and these are very successful to this day, especially in the right indications. I would advise you should pulse back the graft to get rid of the marrow elements before you put the bony part in. Autografts, including mosaic plasty, became popular in the early 90s. Haggerty described this in 1994. And then, as we indicated, Macy became popular. It started with this landmark publication by Peterson and with ACI in 1994 in the New England Journal of Medicine, and gradually became more popular. It's interesting that the second generation of Macy lasted only a matter of months before Macy then became, with the Matrix, the last and most current generation of cartilage transplantation. Here then is a summary of the articular cartilage surgery we talked about. And now on to Dr. Dudek's favorite topic, the history of the patellofemoral surgery. Again, this will be just brief. And so Jack Houston in 1964 said recurrent subluxation and dislocation of the patella remains unrecognized and one of the major causes of internal derangement of the knee joint. In fact, many people have called patellar instability the great mimicker. So let's talk about chondromalacia, lateral patellar compression syndrome, patellar malalignment, patellar height, the MPFL, trochlear dysplasia, and patellar arthrosis. So chondromalacia, softening of the cartilage, has been described since the early 1900s. And Wiles in 1956 said that until there's an adequate way of measuring this, the patients must retain uncertain and treatment can be basically according to the art or trade. And so this gradually became more and more recognized as a real entity, and it requires you to actually visualize it. And that's why arthroscopy helped with the management of this. And then we got into lateral patellar compression syndrome. And one of the most overused surgeries in our era was the lateral release. People would use a lateral release for a variety of problems, and they always fail because there's very limited indications for lateral release. That is a very tight lateral retinaculum that's failed non-operative management. And only then should you do a lateral release or a Z-plasty. How about patellar malalignment? This became more recognized as we developed techniques for axial evaluation, axial imaging, first Picot and then Merchant, which uses the view we use today. And as Dr. Dudek indicated, there's various different techniques for measuring this. As PTLTR that you've been introduced to today is a very helpful adjunct to evaluate on CT or MRI the axial malalignment. And so techniques to address this included various different medialization procedures gradually over the years, and ultimately with different techniques in soft tissue grafts, and ultimately the anterior medialization is popular as today that moves the tubercle both anterior and medially as popularized by Fulkerson. Various ways to measure patellar height. The most recent, as you've heard already today, is the CD ratio, which we use, and it appears to be the most accurate of all these different measurements. And the way that you address this is with correct the patellar height with distalization when needed, which is more popular than the soft tissue procedures. How about the MPFL, another rediscovered ligament in our lifetimes? And really, this has been existed all along. And it's just that we recognize that the anatomic location of it that was popularized by Schottel is something we measure every time we do this today because bad results with non-anatomic procedures, which is a recurrent theme here. Trochlear dysplasia, popularized by de Jour, both his father and David de Jour, who popularized this classification technique and the importance of recognizing these bumps or humps or problems. And so that led to the development of trochleoplasty, which, of course, our partner, Dr. Dudek, has popularized here at our institution with very good results. How about arthritis? Well, the use of the treatment before 1970 was just take the patella out. And of course, that had significant problems and gradually led to either allografts, Macy, or arthroplasty. Here's the history then of the patellofemoral surgery. And let's conclude then with the history of knee arthroscopy. Again, thanks to Winston, who has a whole talk on this, and we'll just summarize it briefly. So the quote here, I think Robert Jackson's is the best. Arthroscopy must be considered one of the greatest contributions in orthopedic surgery in the 20th century. That's saying a lot. And so here in Europe, it had its beginnings in the early 20th century. And then, of course, the real forefathers of modern arthroscopy are Tagiki and Watanabe. they developed 22 different arthroscopes over the years that led to what we now know as arthroscopy. And perhaps the most largest leap was number 22 arthroscope, which used fiber optics and allowed us then to visualize the joint without light bulbs or other techniques that were not very successful. And so Watanabe was apparently a very unselfish teacher, and he taught many North Americans who came over to learn the tricks of the trade. And many of these included Bob Jackson, who visited Japan in 1964, O'Connor, our own Cassels, who published the first article on knee arthroscopy and wrote the first textbook of arthroscopy. And then McGinty added a TV monitor because in the past you had to look in through an accessory lens. And the TV monitor was a very great advance, as have all the TV monitors over the years. So here really are the legacy, the founders of modern arthroscopy in at least North America. So this is a history of what we've done. This is the history of sports knee surgery, all the way through the cruciates, the collaterals, the meniscus, the cartilage, patellofemoral joint, and knee arthroscopy. And throughout all of that, then what do we learn? Well, first of all, anatomical procedures work best. 2-year follow-up often isn't enough. If you want to be known as the first person to do something, then publish it first. If you're first to describe something, check and then recheck the literature, including the European and the other literature. Don't be fooled by so-called experts. If something looks stupid, it probably is. Don't reinvent the broken wheel. And unless you're doing legitimate research, don't be the first or the last to adopt new techniques or to abandon techniques that don't work. And so with that, this concludes the first talk, and that is the history of sports knee surgery. And with your permission, then I'd like to go on to our next talk, and we'll take a few questions at the end of this talk. And so this really is what I think Bobby wanted me to talk about, and I'm sorry I'm spending less time on this than the other, and I hope I didn't bore him too much. But we're going to talk about career reflections, aphorisms learned along the way. And to remind you what an aphorism is, it's a pithy observation that contains a general truth. Pithy, yes, a concise and forcefully expressive. And that's where we are. That seemed appropriate. So with this talk, first of all, I apologize if you think this is all about me, and it certainly isn't. And so hopefully I just want to share a few things I've learned throughout my career. And I'm very proud of what we've been able to accomplish. And I think that you know that indeed I'm not necessarily the GOAT, but I've enjoyed my time in this career. So let's talk about aphorisms. Again, we're going to use Aristotle's concept of telling them what you're going to tell them, and then tell them what you told them. So here's what we're going to tell you. We're going to talk about fish and ponds. We'll talk about time management, surgical performance, leadership, the 3 A's, as I'm sure you've all heard, communication, the importance of lifelong learning, respect, a few aphorisms from Alan Anderson, and then some final advice, all in less than 10 minutes. So, fish and ponds. It's easy to be the big fish in a little pond. It's harder to jump to bigger ponds. But when you do jump to other ponds, don't forget about the other fish. Time management. Randy Pausch, who unfortunately, very tremendous speaker and thought-provoking person who died early of pancreatic cancer, but he understood the value of time. And he said that bad time management leads to stress, and good time management leads to success. He always says to do the right things. You don't always have to do things right, but you have to do the right things. He talked about the importance of multitasking. And he also had a little advice about your inbox. Your email inbox is not your do list. Make a separate do list, and don't follow based on what people bog you on your inbox, including all the emails from your chairman. So make your own do list and do what's important first. So let's talk about that for a second. So when you make your do list, you should, first of all, put it in categories. What's due soon? What's due later? What's important? what's not important. So obviously, the first thing you do on your do list is what's important and due soon. Now, here's the catch. The second thing you do on your do list is not what's due soon and not important. Instead, it's what is due later and important, because you should do the most important thing first. And then if you get time, you can do those things that are not important, and those things that are not important and shouldn't maybe even do at all. How about surgical performance? Well, I suggest you should have a plan and even have a plan A, B, and C. This is particularly true for complex cases and multiple ligaments. We routinely have a list that we develop, all the steps of the case, go through it with the surgical team, and even post it right there in the room so that everybody can look at that list and know exactly where you're headed. And share this plan and do the plan so that everybody gets involved. I often said there's no simple surgeries, only simple surgeons, or there's no simple arthroscopies, just simple arthroscopists. So you need to realize that every surgery is not easy, and every surgery needs a plan. And then do your part, no matter what level you are, whether you're at a community practice or in an academic practice, to teach others. And teach other surgeons how to do good surgery, because they may be your surgeon someday. Remember the 3 A's: affability, availability, and ability. So again, they're self-described, but I think probably more important is the availability. See anybody, anytime, answer the phone, and allow people to come in and see you. Have an open door policy whenever you possibly can. Surgical performance. My old chairman in my residency program told me it doesn't matter who goons you, you're still goon. So everybody's important, and everybody can also drag you down. I often said in the OR, if there was a problem, I'd say, no problem, no problem. And the more often I said that, the more the problem there really was. But you need to just roll with the punches and get through that. And don't be afraid to ask for help. And then never leave the OR unhappy. Your only chance to avoid a quality assurance issue is to assure quality before you leave the room. So if you're gonna take an x-ray in the room and fix it in the room. Otherwise, you're gonna be in Wednesday morning conference. Leadership, lead by example. My father used to talk me to look yourself in the mirror. And so if you're not happy with yourself, you shouldn't be happy at all. Listen to your team, engage your team. I would often tell folks that I want you to make my problem your problem and solve it. And that way we can get to the right answer. Try to inspire others whenever possible. Communication. Have regular meetings with your team, follow up on issues that are outstanding, arrange for consultants and referrals, talk to everybody, provide instructions, be careful with the media and press, plan ahead. And Alan Anderson often said to underpromise and overachieve. I have some paragraph rules. I like to have people present a case or a condition with one paragraph. And that will force people to get to the bottom line and really emphasize what's important. So I call that the one paragraph rule. It's a great exercise for students. Try it. And then for emails and other correspondence, I have a 2-paragraph rule. If you're writing more than 2 paragraphs, we don't want to read it, and we're not going to read it. So just get to the bottom line. Lifelong learning. Learning never stops. Always try to get better. Seek all opportunities. Read, watch videos, go to meetings, go to labs, do research. Perhaps one of the best ways to learn is to make PowerPoints of talks. Go to skills courses, diversify. There's no such thing as a book that has every trick in it, so don't keep looking for it. And don't get stuck, just keep learning. We've already talked about these lessons from the history lesson. I emphasize those again to you here. And then respect. Be proud of your heritage, especially a place like this. Honor your mentors, support your partners, love your institution. And then, as Mary Lloyd Ireland once said, don't demand respect, earn it. A few more aphorisms from the late Alan Anderson. He says, nothing's so bad you can't make worse, and nothing's so simple you can't screw it up. Everything takes twice as long as you think it will because you're only half as good as you think you are. And he said, arrogance leads to conflict. Humility leads to harmony. What a great leader he was. Final advice, perhaps some of our politicians could adapt this. Don't be afraid to apologize. I used to always advocate for people to say, you're right, I'm sorry, it will never happen again, whether you mean it or not, and then move on. Something we never understood during my training was work-life balance. And I recognize the importance of that now, and I wish I would have done better, but I encourage you to try to do that and also try to learn outside of orthopedics. I was always too worried that I would forget something and not read orthopedics, and so I wouldn't read novels. It was just silly. So expand your whole repertoire. Try to embrace the arts and really get a good balance. Reward your team whenever possible, whether it's a lunch or a catered event or just spending time with people, and enjoy the ride. This has been a great ride for me, and I hope for you as well. So as I ride into the sunset, I want to appreciate my spouse and her success for me. So, like we said, Aristotle, tell you what we tell you what we told you. This is what we talked about, and including some final advice, and certainly happy to take questions. Thank you.
So Mark, one question. I'll let you get off.
All right, go here.
So look back at your storied career. Most recognized name in orthopedics, probably worldwide, to do your review courses and your books and your contributions. If you had to think of one thing you would do differently, what would it be?
Yeah, I think I probably would try to be more personable. I would seriously. I mean, I'm a cubicle mentality. I'd get into the cubicle and I'd focus on what I'm doing and try to get my stuff done and progress with whatever project I'm working on. And I never took the time to really get to know people and learn people's names better and try to embrace the other fish. And so I wish I'd do that better.
What about one thing that really made a difference in your life or career that you may not have recognized in the moment?
Yeah, that's a tough one. I think the challenges that I had in my training, particularly at the Air Force Academy, and then the engineering path I took on and the military background I had, I didn't realize how important that was all it was until I got to the point where I could understand the importance of summarizing and basically trying to organize things the way I could understand it. And unfortunately, that's the way a lot of other people understood it too. So a lot of my contributions were initially selfish to try to figure out how I could get things simpler to understand. And I was able to share that with other people, fortunately.
Thank you, Mark.
Yeah, my pleasure. Thank you, guys.